Irene, now that you're the host, can you please make her co-host so she can share her slides?
Sure. Yeah. So we are live.
Great.
Okay, and now Katharina, you should be able to share your screen.
Yes, okay. Can you see it?
Yes.
Okay, then try this. You still can see it, or do you have, because I have more monitors here, you have the right view?
Yeah, now we
Yeah.
have the proper view.
Yeah, okay. So I never know which one is the one who is shown.
No,
Okay.
this one works.
Yeah.
Hey, everyone. Okay,
Okay.
I'm gonna leave it to Irene to introduce you.
Yeah.
But good to see you. Thanks for being here.
Okay. Okay, so welcome everyone. So Katharina leads the electrophysiology unit at the University Hospital of Regensburg in Germany, and she is responsible for the preoperative mapping and surgical planning of neurosurgical patients, and she does her studies with both fMRI and DTI data. She works with awake surgery, perioperative neurocognitive assessment, and intraoperative neuromonitoring. Apart from the neuro monitoring, she manages all these procedures independently. And with these techniques, she's able to generate really rich and consistent clinical data sets. And she brings over 20 years of experience. And the past 11 years, she dedicated them exclusively to the neurosurgery patients. And in today's talk, she will tell us about the intraoperative language management during awake craniotomy in brain tumor patients. So welcome, Katharina, and the floor is yours.
Yeah, thank you for the very nice introduction, and I'm really happy to talk today and thankful about my bits of my works and my interests. And my talk is about the intraoperative language management during awake craniotomy in brain tumor patients. If you're facing a tumor like this one, the standard of care is a neurosurgical approach to resect the tumor because the tumor is infiltrating and displacing healthy brain tissue, which leads to symptoms as seizures or functional deficits. Unfortunately, every brain tumor is, in comparison of the rest of the body, if you find a tumor in the lung or so, is surrounded by networks cortically and subcortically of different brain functions. And because of its close relation between brain tumor and function, we have a very high risk of developing post-surgical deficits within a brain tumor surgery. So it is very intuitively that we do not want to harm brain functions. Yeah, so because we all know this will cause deficits as aphasia, hemiparesis, hemiagnosia, and so on. Therefore, in neuro-oncology, there is a core principle which is called oncofunctional balance, which means the maximal reception of a cerebral space occupying lesion by minimal risk of post-surgical functional deficits. In this aspect, maximal tumor cell reduction and minimal risk for post-surgical functional deficits is essential and both equally important for the brain tumor prognosis. So a patient with, for example, a hemiparesis after surgery lives significantly shorter than a patient without this deficit. And this is also associated with response to subsequent therapies. Patients with post-surgical functional deficits, they just benefit less from therapies as chemotherapy or X-ray therapy. And of course, it has an impact on post-surgical health-related quality of life, including return to work. So there is a need for perisurgical mapping and monitoring of brain functions. Mapping means localization of brain functions, and monitoring of the integrity of brain functions. This mapping and monitoring can be done perisurgically, like pre, intra, and post-surgical, but also, and I won't talk about this anymore in the talk, but very important, during the whole course of disease in these patients. We now have several methods of perisurgical functional management. Pre-surgically, we obviously first have neurocognitive assessments and the functional imaging, including fMRI, resting state, fMRI, TMS, and DTI, just to name the most prominent ones, in order to localize cortical and subcortical brain functions, to give or provide some information for the neurosurgeons according to critical areas in the brain. But also intrasurgically, we have methods, asleep and awake. Asleep, we have the intraoperative neuromonitoring, and I think you heard about this quite a lot from Kathleen Seidel a few weeks or months ago. Here, we just or focus on very basic functions, for example, the sensor motor system, but we also can map and monitor parts of the auditory and visual pathway or the integrity of the cranial nerves. When it comes to higher cognitive functions, the most prominent and well-established method is the awake craniotomy we will use for function mapping and monitoring. I want to dive more deeper now in the intrasurgical language management especially. Language is, as we all know, a large-scale network which is organized cortically and subcortically around the sylvian fissure. Unfortunately, we have a high frequency of malignant brain tumors, tumor occurrence around the sylvian fissure. So it is very possible that the brain tumor patient has once during his disease the risk of post-surgical or in general language deficits. As for example, a patient we see here, a patient with a temporal parietal tumor in the left hemisphere, where we could see after pre-surgical functional imaging using fMRI and DTI that this tumor is in very close association with cortical fMRI language activation, which we can see in yellow, but it's also very near located to the arcuate fasciculus in turquoise, and in orange, not very close, but also close to secondary visual areas as the visual word form area, which is important for reading. So also this patient needs a standard of care brain tumor surgery. But of course, this patient has a very high risk of developing during the surgery, after the surgery, language or speech deficits. So we would probably offer an awake surgery to this patient. When it comes to language, the oncofunctional balance gets especially important because we see here in this data, in the blue curve, that patients who show post-surgical language deficits live significantly shorter than patients without speech and language deficits, which is the red curve. And this effect is especially pronounced for language. So it's less dramatic if we talk about sensor motor deficits or vision deficits, for example. So this is data from our own institution. The principle of intrasurgical language mapping is a combination of direct electrical stimulation and speech processing. Thereby, the neurosurgeon stimulates specific areas of interest with a biphasic pulse duration 1 milliseconds, 50 hertz, with a very low frequency current of 0.5 to 3 milliampere current. And thereby, he tries to simulate a lesion. Simultaneously and timely triggered to the electrocortical stimulation, the patient is performing language tasks. And then it can happen that the patient starts or not starts, or just is not speaking anymore, like we see in the left image. I don't know if you can see my mouse. Can you see my mouse? Yeah. Here where the green dots are, here the patient showed language deficits during the electrocortical stimulation. So he stopped speaking, he made semantic error, grammar errors, and so on. And during stimulating here at this area of the red spots, the patient did not show any language deficits. So the neurosurgeons then knows, okay, I can do a safe surgery in this area without harming language, but not here. And one has to be especially careful around the borders here, and sometimes also sparse some brain tumor because function can overlap with brain tumor areas. So basically, we do a language mapping at specific time points during the surgery, at the beginning, or also during some later time points. You can have several of these until the end of the surgery. So we have at specific time points information according to language location and language performance in the patient. With this method, we cannot really know what it's in between these specific time points when the resection is going on. I will talk about this issue at a later stage. First now, I want to focus on intraoperative language task selection. So what are we doing with the patient to examine language? So we all know this. Language is a huge system, first around the Sylvian Fisher with its core language system. We also have some lower level, very language specific bottom-up system dealing with perceptual and motor aspects of language. And this is also connected with higher cognitive top-down networks, which are mainly important for memory-associated language function and executive control of and management of language subfunctions. So a very complex network where we have to deal with when a tumor is located in this network. When it comes to the language itself, one has to really think what functions can be affected during a brain tumor surgery, probably also associated with brain tumor location. So are there deficits according to morphophonology, semantics, syntax and grammar, speech and articulation, pragmatics, so even higher language functions, or even secondary language functions, reading, writing, fluency, and so on, or our combination of these functions can be affected during the electrocortical stimulation during awake surgery. And then one comes to the point, how can I test this function and which tests are actually available already? So I can tell you now, there are actually very rare attempts according to standardized intraoperative tests or protocols in the moment. In the literature, there are quite several reviews out, of course, based on some evidence. They are all location-specific approaches. And for example, here in this review, the authors support little language test batteries according to brain tumor location. For example, a brain tumor in the temporal lobe would need 8 subtests to test language sufficiently in this review. And 8 tests is quite a lot during a surgery and will take quite a lot of time. As I said, we do not have standards here, so every center, every institution is making their own protocols, is making their own stimuli. So first of all, we have to think about validity of the single tests, stimuli, or combination of the tests. Do they really measure language functions we want to measure? Then time, as I already said, 8 tests is a lot. How many tests do we really need to valid test our language? Are probably redundant tests included? So for example, from my opinion, I'm not so sure if one needs tests like word repetition in combination with non-verb repetition. I don't know if if it's so important, or it gives you so much more information during an awake surgery. The next issue is the paradigm design itself, the saliency. There are very easy paradigms, as we can see here, and there are very complex paradigms on a perceptual, superficial level, from my opinion, and also on a cognitive level. So one has to be very careful in these complex paradigms, because it can happen that we address during the stimulation here not the language level itself, but a more cognitive, higher level, or even perceptual level. And for example, here the patient is just not doing the task, he stops talking or makes a mistake. This can be due to some other reasons than language. Yeah, this is often neglected in many paradigms. And of course, we also probably always need a little individual approach according to our tests in means of patient's characteristics. So is our patient already showing speech and language deficits? And it's not impossible to do a language mapping with a patient with a mild aphasia, not at all. The age, the education, or bilingualism, and all this just may play a role in task selection and task generation. Nevertheless, the most used task is picture naming, followed by reading, sentences, words, and so on, and verb generation. I just want to focus a little bit here on picture naming in this one slide. It's the most common task. It is a very salient and easy task. This is what I really like from this task. The task here is that the patient is visually presented with a picture, and he has to generate, he has to name the picture by generating a short sentence. So he has to say, this is a plane. And thereby, 3 categories of errors can appear. We can have semantic errors like semantic paraphasia, circumlocation, or word finding areas. We can have, in a second category, morphophonological areas like phonological paraphasia or neologism. And we also can have very superficial areas at the performance level, like dysarthria, for example, or speech arrest. These are quite a lot of categories I think one could test with this very easy task, but of course we cannot cover the whole language system with this task, but this is really mostly used in the community. There are several other attempts to bring a little bit more sophisticated approach to this, and a very elaborate approach, from my opinion, here is the Dutch linguistic intraoperative protocol introduced 2015. Here again, they provide location-based, a minimal set of tests which should be used or can also be combined for a sufficient language testing. Here is the cortical level represented, but very recently they extended the network also to or the toolbox to subcortical functions very nicely. In Regensburg, I use a completely different approach from this. I use a sentence generation task, which is a combination of a picture naming task and a verb generation task, with the aim to test as many essential or critical language subfunctions as possible within one task, just to save time. Hereby, the patient has to generate a sentence either of a picture and one word or 2 words. So we have 2 versions, easier and a little bit more complex one. So it is quite possible to test most essential linguistic function with this task, of course, also not all. And this is also reflected here in speech and language area we see in our patients. Disadvantage is this task can be challenging sometimes, especially, for example, if patients have problems in naming objects or animals. And this is quite often happens in brain tumor patients. Then you really have to switch to another task like verb generation, for example. And the task can be difficult in patients who have problems in attention, and also this can happen in brain tumor patients because the patients have to be able to do one stimulus in between of 4 seconds, because we only can stimulate for 4 seconds, because after 4 seconds the risk of the intraoperative risk of seizures increases dramatically, and we want to avoid this. So if a patient is not able to do this task very easily in 4 seconds, we cannot use it and need to turn to easier tasks. But I would say in most of my patients, I can use this task very successfully. Coming now from task selection to some aspects of direct cortical stimulation or electrical stimulation, which is one of the most neglected issue in awake craniotomy, and I still can't believe it until today that it is like that. So we are using this method all the time, but we do not know a lot about this method. We do not know a lot about stimulation, timing, and duration. And here is just as an example for picture naming, the sublinguistic processes and which happen when I have to name a picture, like I have to say this is a goose. Sublinguistic and linguistic processes take place very incrementable, very one after the other. And there is a strict timing is what I want to say. And in general stimulation, intracortical stimulation, we stimulate 1.4 seconds before stimulus presentation. This is just the rule. To do this with the aim to block the whole speech production process. So we do not know what would happen if we would stimulate earlier, later, or simultaneously to a picture presentation, or probably we could also use the stimulation and stimulus onset association to address several aspects here of this whole sub-processes. Nobody knows. We're just doing it all like that. And unfortunately, since we're using medical products, we are forbidden to connect our stimulation device to like a computer where we could do a proper timing and triggering. It's impossible. So we will have a very heterogeneous timing in every testing we do, because it's impossible to do it always at the same time. Additionally, we do not know anything about the effect of the location of stimulation. So for my opinion, it is so there will be differences in stimulation properties when we do frontal or temporal stimulation, for example, because there are different neurons, different neurotransmission systems, and so on. But we do not know anything about this. We do not know a little bit. We do know about stimulation threshold, but not a lot too. So in the end, stimulating is mostly a non-off effect. So of course, stimulating with higher current can lead to different symptoms, but sometimes, as for example, there were symptoms in patients when they stimulated, they found with I don't know the thresholds, with a low threshold, I say a 0.5 milliampere. They had some word finding problems, and then they increased the threshold, and then they stopped speaking completely. So, but what does this mean? This also could be some seizure. We do not know really. So threshold, nobody really knows, but at least there are some and few studies out. We do nothing know about local tissue effects. Most brain tumors are surrounded by edema. We do not know how this affects stimulation. It could felicitate or inhibit stimulation. We do not know at all. And also tumor grade and biology, there is nothing known how this affects or interacts with stimulation. Here also, from my opinion, there should be effect, for example, in IDH mutated tumors, which are tumors which go along with a lot of seizures. There probably must be some interaction with the threshold. Another second aspect here, and this goes a little bit beyond the real intrasurgical situation, is when it comes to direct network stimulation effects. For example, in case of negative mapping, this is something we often see, and I do not often see it, but it's reported in literature when you deal with higher cognitive function as language. So you do your stimulation and your functional mapping, and the patient does not show a deficit. But during the surgery or even afterwards the surgery, the patient develops a functional deficit. This is probably due to this non-locality of higher order functions as language, from my opinion, because these functions are organized in complex dynamic networks. As for example, here, this is just from a publication of Linda Bauer recently. It's not language, it's just any networks, but we see here that there are hubs that are just more connected with other hubs, like this one here, and probably are even there are even stronger hubs, and so probably it has more effect if we stimulate here this hub during the surgery. Probably we will see a language deficit or a stronger deficit in comparison to stimulating this hub. This is information one could, of course, get before surgery. This will be very inter-individual, but it also can be different in an individual. For example, if it comes to recurrent resection of a brain tumor or probable even during surgery, from beginning to the end, all these dynamics can change because the neurosurgeon manipulates the networks or just connected networks. So just some reflection why this is so difficult. First I talked only about the language mapping and how difficult it is to perform this, but another aspect is the language monitoring. Language mapping, as I told you, provides only temporary feedback about language, location, and performance, and is not really helpful in managing transient performance decline, which could happen, and according to negative mapping. Therefore, one would wish a continuous language monitoring, so that language is continuous monitored during the whole surgery, the whole resection process. Here again, there is the question, how can I test this and which tests are available? And at this point, there are even less tests available than for language mapping. Actually, there are almost no reports in literature at all. This is what I tell you now is just what I do and what I talked to what our colleagues doing. Most people use spontaneous speech during language monitoring. Sometimes they use standardized interviews, so you talk to the patients about their last vacation, their hobbies, their work, but especially if brain tumor surgeries are very long, then you can run out of material, and then it gets a little bit difficult. And also patient can cover and mask deficits very, very good during spontaneous speech. I am personally like to use picture description tasks because you can do them very structured and semi-standardized. Sometimes I also use storytelling, which you have to train with the patient before surgery, of course. And in some patients, you also could do reading the whole time, especially if a tumor is located to the visual workform area or to more areas in the near of the articulatory motor interface. Of course, here also we have no protocols. We have no normative data. Also for the mapping, there is no normative data around. Everyone does what he wants to do and designs everything by himself. I just want to present you a very sophisticated approach, which recently was developed by the team of Barbara Tomasino, according to the Intraoperative language monitoring and also neuropsychology testing in an extended version. She uses real-time neuropsychological testing or just developed it, which is a continuous sequential monitoring of different language functions. Thereby, the patient is continuously performing sets of different individual language tasks while the complete surgery from the beginning until the end of the surgery or the resection. This is only interrupted or interleaved by phases of language mapping using direct electrocortical stimulation and mapping tasks. The advantage is that it's really very good continuous language surveillance, especially to detect some transient cognitive declines. The disadvantage, of course, is that it's cognitive very challenging and exhausting. And for the ones who already did monitor testing in the intrasurgically, even things like just spontaneous speech or picture description is very exhausting for the patient, but also for the examiner. And this is even more exhausting. So to sum up these points, intraoperative language mapping and monitoring is needed to improve the post-surgical outcome. The task selection according to language task is challenging, and it's also challenging for other higher cognitive tasks, but language is the most established function intraoperatively awake. We have very low evidence according to electrophysiological parameters, especially according to the stimulus onset time. Picture naming is still the most common task used, and it's not the worst, to be said, but it cannot cover the whole language system, and probably even more individual approaches are needed, especially in means of network connectivity, but this is still in its baby shoes. Even there are approaches. So even if we don't have standards and protocols, it's not the case that the community is not aware of. And recently, there was a consensus paper of the Pioneer Consortium who is just trying to harmonize language mapping during institution and countries, but it's still at the beginning. In the end of the talk, I just want to show you the case of the patient you already saw in the beginning and how awake surgery worked in this patient and how it helped the patient. Yeah, it's just 3 slides. We saw these patients before. The patient showed up in our clinic. She reported subtle, subjectively word-finding deficits. And when we did the pre-surgical imaging, including functional imaging, we saw this close association of language critical cortical and subcortical areas and the brain tumor. And we also did a neurocognitive assessment, and we found a very high cognitive level over all domains in this patient, except verbal working memory and several language skills, including verbal fluency, but also some semantic tasks. And therefore, because of their good other cognitive status, we just offered an awake surgery to this patient. And during the surgery, I used, as I most often do, a sentence generation task, as I showed you before. I always train the simple and the complex variant with my patients in order to always have a backup during the surgery, where we could, for example, switch from the complex version, like here, to the easier one. If the patient can do the complex version until the end, I always prefer this because it's just more specific and sensitive, but sometimes we have to switch to the easier one. And this was the case in this patient because she gets very tired. The surgery took very long, and we had to switch to the task. Here we see some stimulus-associated errors, which are not really quite different between both variants of the intraoperative language task. We saw a lot of speech arrest and word-finding problems. We saw deficits in morphophonology, in grammar, and especially in the task with the more complex character. We also found sentence structure deficits or syntactic deficits, and we found reading deficits. And these deficits could also be assigned to specific stimulation locations. So stimulating more dorsal. So here in this yellow parts, this led similar to stimulation of the arcuate fascicle to speech arrest and morphophonological problems. And in case of the arcuate, also to grammar deficits. And stimulating here to this more posterior ventral language areas, we found especially grammar and syntactic deficits, and very not surprisingly, stimulation in the visual word fang area, patients will not be able to recognize words anymore, but this is not really linguistic, it's an agnosia, yeah. 3 months after surgery, this patient again showed up in our clinic, still reporting subtle, subjectively noticed word finding problems. But the patient was again still working, partially, not full-time anymore. We could see that the brain tumor was resected totally, which is very nice, but in the end it turned out to be a glioblastoma. And the neurocognition was also very stable, very good still, and even improved according to verbal working memory, which was on average now, which was beyond average before surgery, and language skills also improved dramatically, even to above average values. So this was my last slide. I thank you for your attention, and I'm happy to hear your questions.
Thank you so much, Katharina. It was very interesting and very dense presentation. So, okay, we already have a first question from Lilith. Go ahead.
Hi, Katharina. Thank you a lot for this presentation. It was really interesting. I have a lot of questions, so if there are other people, just raise it and stop me. So the first question is, why are there tumors most of the time in the language areas? Is it because we are not capturing those who are, I mean, they are not as devastating as those that, I mean, the most noticeable one is the language deficit, or is there some, I don't know, study on why the occurrence of tumors are usually in the language areas?
Probably you cannot say they're only and usually in the language areas, but they are quite often there. And I think this is also due to anatomy, because there are many wide fiber tracts, and it is known that tumors like to grow with these fiber tracts, to use that. So my colleague from the cell research, he always says they use it as a motorway. And this might be one reason, but they are not dedicated to be there. Special tumors with special molecular characteristics are definitely, like, for example, in the frontal lobes, are often in there, but also due to some molecular characteristics. I think it's just a coincidence of, yeah, anatomy and some properties or characteristics of these tumors. So it's not that they want to be with language per se, yeah.
Yeah. No, okay. Next question that I have, I never paid attention when I was reading papers about direct electrical stimulations, if they ever mention the threshold that you was talking about it, because I mean, it felt too technical for me detail, but now when you mentioned it, this is really interesting and important to report, because otherwise how can we compare, you know, the results about what kind of function this area is involved in. So if there is no information about thresholds, it's really becoming challenging to kind of derive any functional relevance to those tracks or regions. As you say, the same area can show word retrieval problems, but and then speech arrest, and it can be then named that this area is involved in speech initiation, but in fact it was some threshold differences. So I don't know, is it something that people report at the moment, or?
No, they report the range they're using.
Mm,
The problem is that it is very individual according to this thresholds.
yeah.
This is also individual for intraoperative neuromonitoring, even there. And one aspect I actually forgot in the presentation I just mentioned, probably there's also an effect if patients already have some deficits. Also, this could also affect the threshold, but it's not reported. But the problem is you would have to report it for every single subject then. This would be interesting, but sometimes if the threshold is too high, you provoke a seizure. Yeah, then you cannot really differentiate. We have possibilities to differentiate between seizure and real deficit with other electrophysiological method as the electrocorticography, for example. Yeah, but even if the symptoms change, it's really difficult, and there are no reports. And this is one problem. It's really not comparable.
Yeah, also like even with transcranial magnetic stimulation, right? There is also
Yeah.
a threshold difference, and also like depending where you are stimulating.
Yeah.
It's also another problem
Yeah.
on that method. Thank you. Okay, I have a last question maybe, and then like after Muge, I do another one.
Yes, we have time.
So you mentioned that patients during surgery, they can actually mask their deficit pretty well. What do you mean by that?
It's always in patients with aphasia. If they have a very mild aphasia, then they try to avoid talking about things they cannot talk about. For example, I don't know if I had a patient like this on Monday, actually. He was really, really good. He could speak fluently, but he avoided specific things. Like, for example, the naming was a real problem. So I couldn't do any naming task at all, but he could talk fluently if he didn't have to name. And I can't remember really some examples, but I think this can happen quite easily. And they repeat then, if they do not know what to say, they repeat something and use words more frequently. And sometimes they can be really good if it's in this.
Yeah, interesting.
And deficit can be overlooked, just never.
Yeah, that's another challenge then to that's, as you said, for the spontaneous speech then. Yeah, thank you. Then Muge.
Hi, Katharina. Thank you so much for this very interesting talk. I had a couple questions. The first one is a short one. So you mentioned that there is no standard protocol for mapping different language functions intra-op. Are there standard protocols for mapping other functions like memory or I don't know, like
No, even less,
even
less.
okay.
Even less, yeah, even less.
Yeah.
I think sometimes it's really critical. I think that the most problem is this timing, also what I told you, but we even do not know by the most used task intraoperatively. We do nothing about the timing. And it gets even worse if I come to like higher executive functions, memory. Yeah, there are so many parts of memory and it interferes with the stimulus material per se. It interferes with the complexity of the stimulus and so on. No, there is no data at all.
Yeah, and my second question was relevant to the timing. So, for example, the task that you showed us, the elephant drinks. So they see a picture first, and then they have to like conceptualize what they're going to say, and then they also have this, structure building, like the syntactic form of the sentences, and then production. So basically, the motor function. But when you stimulate 1.4 seconds before the picture appears, it's not possible to disentangle which process you're preventing or manipulating. So that's why, I mean, is there why is it not possible to like stimulate post like after they see the, for example, picture? that way, I mean, they have the preparation, like speech motor preparation, but like, for example, they can't do it after, they prepare. They can't do it because stimulation comes after they're prepared. So is there no way to, I don't know.
It is, in general, it would be possible. This is the way everyone does it, just to address the whole process, to stop the whole production process. But it would be possible. But here, I think it would be critical according to the acuity of the timing, as I told you, because we are talking of 100 milliseconds, and it's really, really difficult because we trigger our stimulation with acoustic cues, with tones. The neurosurgeon hears the tone and then he reacts, and he has to react. So he has to hear the tone, he has to react, and I think we were not able. Yeah, probably it should be possible in a very sophisticated setting, but in the moment we are not able to connect the stimulation device with any computer. So as we can do it with TMS or with fMRI and so on. And this is I think the most important issue. So the acuity is a problem.
Yeah, but for example, can you at least like post-stimulation trial ask the patient like what was difficult? Like
I do this.
Okay, can they tell like I actually knew what I was going to say, but I just couldn't produce it, or I didn't, they can.
They can, because I also train them in advance of the surgery that they should tell me this. I train them even that they.
Yeah, that's also informative. I
know.
Okay, thank you. Thanks so much.
Yes. Go Stephanie. I think you were first. No? Yeah.
By a millisecond.
Yeah.
So I was just wondering, you say you train your patients and there's a lot of assessment. So from start to finish, how long does one patient workup take, and how much time do you actually have in theater to assess their language capacity during surgery?
So the preparation takes at least 1 day, I would say, including neurocognitive testing. We are not doing this all on 1 day because it's too much for the patient. Yeah, preparing the surgery. In the surgery, every stimulus and using during surgery, I train with the patient in advance, because you never know. He doesn't recognize that this is a tree because he knows other trees, so he must have seen every stimulus, and I must know that he can perform every stimulus. So you have to train them. And you have to talk to them about other aspects, like, for example, that they should think what was difficult, but many other aspects according to seizures and so on. So you need, I would say, this a day. Mostly we do it on 2 days. And during the surgery takes, in our case, 6 to 8 hours. The testing is, I would say, 1 to 2 hours. Depends on the patient. Probably there are some patients we cannot do that much testing, but yeah. And it's like, it's very exhausting. In Regensburg, our patients are awake the whole time from the beginning when they enter the theater, they are, until the end. And we do just some local anesthesia in these patients.
So you don't do a sleep.
No,
you keep them awake the entire time.
We keep them awake, but they are just they have some remifentanil just to calm down, and at the beginning of the surgery, but they breathe by their own and so on. Yeah. And in the end, they sleep anyway. So they are so exhausted, they sleep. And of course, we help them a little bit, but in the end, they're awake. And so the patient I had on Monday, he was really fine and nice with this. And yesterday I met him in the late morning, and he was just going to drink a coffee. So this is the advance of this technique, that these patients will recover very, very, very soon from this. And they're just bored when they have to be in the bed a few hours after surgery.
And is there variability? So you don't put them fully to sleep, but they're sedated. Is there variability in how patients respond to the sedation and how well they can perform during surgery?
We did a study where we just looked for very basic neurocognitive function as verbal working memory, and this was really much worse in patients who were sedated. And so we had when I started here 20 years ago, so we had a professor in anesthesia, and he was also doing things like meditation with these patients and things like this. And this is, I only know it that way. So, but my boss here, he came 5 years ago from Hamburg, and he told me they were doing this asleep, awake, asleep there. And he told me that he often could not do the awake surgery because the patients were just so dizzy because of the sedation. But I do not have experience with this really, so we always do it this way. It needs a lot of interaction with the patients before and after, and it needs a lot of trust on both sides. This is nice in one way, but of course it's exhausting.
Okay, I also have some questions, but there was Sampa before and maybe also Vidit. So Sampa, go on.
Hi, thank you very much for your presentation. I have a question about the test stimuli and how often do you have patients that come from that speak a different language, maybe, or even come from or dialect or different culture, and how easy is it to adapt those tests and change the stimuli?
Yeah, I use it then in the other language. I do not have normative data. I translate it. Yeah, and we did awake surgery with Russian people, with Arabic people. I need assistance then, of course, and this is even more. Yeah, it needs even much more time. It's easy to adapt the stimuli. So
you only translate them and use,
yeah,
say, the same
yeah, but
images?
with a native speaker together. Yeah, so that it makes sense. I don't use a Google Translator for that or things like this, of course, so that it still makes sense. And then most often this is just kind of a young fellow here, doctoral fellow who is doing this together with me. Yeah, we did English and so on. And if you mention dialect, if people speaking dialect, I prefer also doing the surgery in dialect. Here we have the Bavarian dialect. I can do this because the people can do the tasks easier if they can talk dialect.
Thank you.
Lilith, you had another question?
Yeah.
Yeah,
I mean,
go.
like, if you, okay.
No, go, no worries, there's time.
So, you mentioned this patient on Monday that was really good at, masking the deficit. But also, is it the same one, but also the one who recovered fast?
Yeah, it's the same one. Yeah.
So I was wondering if you ever notice in all your experience, there is some sort of correlation with the ability to mask and the fast recovery. So, so instead of like kind of trying to assess speech, spontaneous speech, measure more like ability to mask, like in that way to look at the assessments and see if this person will recover faster.
Yeah, with recover, I just wanted to say he's fit and he is speaking fluently, yeah. But when it comes to language testing, like for example, naming, what you really couldn't do, I think he will have deficit.
Okay.
He had already in advance of the surgery, he had also associative agnosia according to animals. I couldn't do any animals in my test material. This sometimes happens. I don't know why, more often to animals than to other things. I don't know why.
Associative agnosia just for animal.
It's not correlated to word complexity or frequency or anything. It's just what I noticed. No, but he is in general like he was before surgery. He didn't. This is what I meant with recover, and I don't know about your question. So I never looked at this systematically. I would have to think about this probably. And this masking thing, yeah, it's not helping him really with his deficits. Yeah, it's masking it, but
Yeah.
it's not really improving the
Yeah.
deficit.
Yeah. Okay. Thank you.
I have a question regarding this part of like the pre-surgical testing. So because I come from University of Padua, and there they apply like the asleep awake asleep procedure. But I know that if the patient is presenting with too many deficits on the preoperative testing, they will not like it's not eligible for awake surgery. So I don't know if you have the same like yeah policy, let's say,
Yeah.
or way of working, or what's the threshold of like how much a patient should be impaired at maximum to be eligible for awake.
Yeah, it is a really very individual decision always. We try to offer this method to as many patients as we can, because then we say it's our problem to make it possible for them. But of course, there are patients which are not able. So especially if they are really, really bad in the neurocognitive assessment in all domains. This is something when I see they're really bad in everything. And additionally, they're physically impaired. And you, it's just always this personal decision what you have to make. But sometimes I think we do awake surgery in patients. Some people don't do anymore. We also do it in children. For example, the youngest child was 9 years old, and this works quite well. As I don't know, so if you have experience with, for example, fMRI in children, this also works very well as long as they can read. So they even don't move at all, less than adults, for example. But it depends. It's really individual, and we try to make it possible for as many patients as possible. But sometimes, yes, sometimes I show the pre-surgical imaging because this is my part in our daily demonstration, and I tell the image says we should do awake surgery, but the patient won't be able. And if the aphasia is already that bad, then it's just not possible anymore.
Mm-hmm. And sorry, Stephanie, I just have a follow-up question on this. So when you do the training and like the preparation for all the different stimuli you use for the specific patient, do you train them in a way that they will see all the stimuli that will be shown to them during the surgery?
Yeah.
And so you also adapt the which stimuli you will show to them if they're presenting like some specific errors on some specific stimuli.
Yes.
Okay.
Because otherwise I couldn't decide if a patient has a problem in the surgery, if it's a general problem, if, for example, he's just not really can recognize, because the object, they're really old ones, standardized objects I'm using, and it's just because it's an old depiction of this object, or if he really has a deficit due to the stimulation just happened.
Mm-hmm.
Of course, stimulation is repeated. Yeah, if we have a positive stimulation site, so if we stimulate on a side and the patient makes a language area, we repeat it 3 times, not immediately. We then go to a completely other side and come back there. At least 3 times we must have positive stimulation until we say, okay, there is function.
Mm-hmm. Mm-hmm. Okay. Yes. And sorry, last thing. Are you also able to disentangle between errors because of language impairment or like language area stimulation or fatigue of the patient, like after, I don't know, like an hour and a half of procedure? Like how can you disentangle that during the surgery?
Normally, the patients are quite euphoric after surgery, because I always visit them at the ICU after, and so normally patients are they sleep right after surgery. They sleep for 1 or 2 hours, and then they are quite fit, quite a lot of adrenaline, I think, still in their body and still working. I don't see fatigue, I think, in these patients.
Okay. Thanks. Steph, sorry.
Thank you. I was coming back like 4 questions now. I was wondering, you mentioned that you do awake surgery in children as well. And I was wondering if the fMRI that you do with the intra-op mapping, if you see differences in the language network compared to adults, because I always thought kids are more bilateral,
Yeah.
but I was recently told that they already have quite a similar language network to adults. So I was wondering what your experience was.
I did not systematically look at this to be honest. So first I look at laterality because it's important with my methods. And then when I decide here we have a left dominance, then I don't look at this more intensively, to be honest. I didn't really systematically look for that. And it's not that we have so many children. Yeah? Probably this is a good idea. I should analyze this data once. But what I experience when I do children, they really have an extreme nice fMRI signal. It's not noisy at all. For an elderly patients, it's often more noisy, and because also due to medication they get for seizures and so on. But for children, it's really very nice, and they don't move for some reasons almost at all. I tell them it's very important not to move, but they're really very sweet.
Amazing, because usually the data is more noisy and
Yeah, I know, but probably these are very selected patients, you know. So it's not that I do every week an fMRI in a child, and then I prepare them quite a lot. And yeah, I'm always carrying a lot of my patients in the MRI. I come in the MRI room every 10 minutes. I talk to them because for me it's very important that they can interact with me and with the tasks. And I don't, probably everyone does it like this, but for me this is very, very important that they always are comfortable, because I know this is just influencing the signal so much. And it's not the case in fMRI, it's also in regular MRI, for example, it's the same. Yeah? And because it's just not that I care so much. I also care a lot of my patient, but I want to have a good signal to have a good interpretation, since I know that brain tumors can interrupt with the fMRI signal. But I think there are so many more parameters in fMRI which can influence the quality of the signal, and I should try to get them as perfect as possible, just to overcome this dysfunctional neurovascular coupling in brain tumors.
Amazing. You must have a very calming influence on the kids.
I hope so. I hope so. And I'm really proud often in of my patients when they can do things, when they're really impaired, they're very old, they're children, and they do the task so well. I'm so proud then if I just see anterior, posterior, and the occipital cortex and a contralateral cerebellar thing, then I'm so thinking, oh wow. And I had the experience, the more intellectual the people are, the more activation is there sometimes. They are even worse. Yeah. They think too much.
We need to get some tips from you on how to get kids in the scanner approach.
But I do very, very simple designs. This is also probably due to that. Block design, always. Best signal.
I use this opportunity to say goodbye to you from my end because my phone's dying, so I won't have signal anymore. But thank you so much, and I leave you with the team. It's been great. Thank you.
Thank you very much that you organized this.
So before giving the word to Hubert, there's actually a related question from the YouTube channel, and so which is related to all the pre-surgical neuroimaging that you perform. So there's this person is asking whether do you run systematically analysis on neuroimaging data like structural MRI, resting state fMRI, or PET for each patient. And if so, which kind of analysis analysis you do systematically, and if you can perform some of them during the operation, which is maybe, I think the answer is probably no. Oh yes?
No,
Okay.
no. The answer
Okay.
is no.
Okay.
The answer is no. I do not have an MRI.
Yeah, okay. Yeah, they're curious about how you're integrating this kind of data for those patients.
Yeah. Yeah, we have, or I have a very systematic approach. It depends a little bit on brain tumor location. I have a systematic kind of language protocol for language function, what I'm doing, but I also, of course, map motor function, sensor motor system, and also the visual system. I do some cortical mapping of the occipital cortex using retinotropy, for example. Of course, I do DTI in these patients. I do a lot of structural imaging, actually, because our neurosurgeons always want to have nice three-dimensional models. I do a lot of, for example, T2-weighted structural images to get a good impression of the place of the tumor, the location, where it is suited exactly. And of course, the analysis is standardized. According to fMRI data, I use SPM in all cases. But when I redo the analysis with BrainLab, because I do not have another choice to do a neuronavigation, BrainLab is not really good for fMRI data. I know this is why I always do it with fMRI, with SPM2, just to compare both methods. And to look what is really there, what signal really exists, or what is just an artifact, yeah. DTI is, for DTI, I use BrainLab. I know it has disadvantages there. I do not use any other methods except for studies. There we use FSL. And we also include PET data. If we have PET data, we don't have them for all patients, more often for low-grade tumors than for high-grade tumors. And then everything is integrated in the BrainLab planning software. And this is the basis where we decide if we offer awake surgery to a patient, of course, in combination with behavioral aspects, yeah, like neurocognition and something like this. Yeah.
Well, that's an insane amount of data.
Yeah.
And you're doing that clinically, not for only for research purposes. So it's really nice. Hubert, yes, go.
Yeah. So I got quite a lot of questions. So if anyone would ask a question to maybe just stop me. But the first one is about the thing you mentioned about IDH mutant tumors, as I understood well, that they have higher risk of making a seizure during the operation, during the stimulation. And I wanted to ask you why, actually. Do you know something about this pathomechanism?
To be honest, I think I cannot say too much to this. I know that they have a higher risk of seizures because they are often low-grade tumors, and low-grade tumors in general often have a high risk of seizure. And they often have seizures before surgery already. They have some medication for the seizure, of course, but these patients in general have higher risks for seizures during surgery. This is just a general risk. And even if they do not have seizures, I see more seizures in patients with this kind of tumors intraoperatively. I cannot tell you too much about the molecular mechanism, to be sorry. This is not my focus.
Okay. So I don't know, is this gonna be something more for your focus? But this you said that there is a mechanism, that there is something that the patients are avoiding the response due the DCS. That is clue that this response, which is the clue for mapping the exact region. So I wanted to ask, this is the subconscious mechanisms, or is it like, do you know something about how is it working actually?
You mean the masking thing I told you? Do you mean the masking thing?
Yeah,
Because,
it was during the first question, yeah.
Yeah, this is not during the mapping. This is during the monitoring.
Oh,
During the monitoring, we do not perform any stimulation. It's just there's just the surgery going on, the resection. Yeah, and during the mapping, this would not be possible that they mask something or avoid something. This is not possible.
Okay. And
this is only if they can choose how to react and how to adapt their language. This is not possible during those tests we use.
okay, and do you know something about how this is working? This is just like, something with the instinct, with some consciousness, or something more like I don't know, something more volitional with their will.
I think it can be mixture of both. For example, the patient I told you now from Monday, he was really aware what he can do and what he cannot do. So, so this is how he tried to mask it. It's not that he doesn't want to show me that he has a deficit. He just wanted to talk to me in a proper way, and this was the reason he could do it.
Okay.
So probably there are patients that just are not conscious about this, but this patient, for example, he definitely was. So I don't have really systematic data according to this.
Okay.
It just was an example of what can happen, and many things can happen during surgery, awake surgery.
Okay. And I wanted to ask also about the stimulation, the DCS, after just resection of all the tumor, when we have the bed after the tumor, are we making DCS in that moment, or we are only making DCS before resection?
No, we making DCS before the resection, often also. It depends on the patient during the resection. So we pause the resection and again do the mapping. For example, if you know now we are coming to some critical areas, because we always try to go as close as possible to these critical language areas. And we also do an after testing when the resection is done. Just, yeah, as a kind of, yeah.
Okay. And the last question is about the nature of DCS, because as I am aware, maybe I'm in the wrong thinking about it, but you got something like the pen that is stimulating the cortex and the parts of the brain. So when you are using this, when I think about the pathomechanisms of how is it working, I'm trying to think that maybe this is, inhibition more of, because you're disrupting the flow of the ions
Yes.
in the neurons. But I don't know, maybe I don't know something. So I wanted to ask about the nature of this. Is it like inhibition for the patients mostly, or the stimulation? Can we control somehow, like with the TMS? Is it inhibition or stimulation type of current, or how is working this pen-like device?
Yeah, it's an inhibition, and it's very local one, because it's like it's a fork electrode, and so then the electric fields of both, they just come together in one point. So it's very specific, and it's an inhibition, of the neurons. So it's like kind of it's not really, but kind of a simulating a lesion at this site.
Okay. Thank you. That's all.
Thanks, Hubert. I have another question, which is more like, I don't know, like reasoning together, or just like more provocative question. So I totally agree with the fact that it's really difficult to map the language function during a setting like that, and that you cannot rely too difficult protocols and so on. But what do you think then of the huge work that the lab, if you know it, the lab of Hugues Dufaux has been doing in Montpellier? Because they're able apparently to map like a lot of different cognitive functions and even theory of mind. So how do you think, like being a clinician that works on the field on this, what do you think about their approach?
Yeah, I know of course I know the lab, and I know their approach, and but their approach is in so many aspects different to most other approaches done all over the world. I think their approach is good, but I think it's difficult to compare the things we are doing with them. And I know that they are doing all these tests and tasks, but probably, from my opinion, probably they already did some work according all these timing aspects before, but theory of mind is such a complex process, including so many sub-processes. So probably they know how to do it. I don't, if you would ask me to do it tomorrow, I couldn't do it, to be honest. I respect this, and I'm impressed always when I see data of the Dufault lab, and when I hear the talks of Hugues Dufault, I'm really impressed. But this is just beyond my.
Yeah. So do you think that it depends a lot on also like the hospital facilities probably, and then
Also, yeah, also. And your experience, so he has a lot of experience with this, and he has a huge team, and this, probably. And I don't say that doesn't work, but I think
just
we need
limited
to know.
for their framework, maybe for their
I need many other. I know many other labs who have the same problems as I have, and. So, and it's not so easy, for example, also to like emotional expressions, to rate them. And so these are such complex processes, which are so fast sometimes. And I just would have to think about a good paradigm, which is easy enough. It's what the saliency is really an issue when you do cortical stimulation, from my opinion. And if you can do it, of course. And I couldn't. I had to think a lot of it, and I think I had to do some experiments in advance with healthy subjects. Actually, what we are doing with our subjects, we did in healthy, we published also this in healthy subjects, that, for example, they are able to do this task in 4 seconds. And we also did fMRI studies that we really can cover all functions we are interested in. It's not that we just went to the OR and did the tests.
Yeah, of course. Yeah. But
Team S would be an appropriate method to deal with all these questions.
Mm-hmm. But I also believe that from the language point of view, you're doing some testing that is not really like the usual practice in all clinics, even big ones. So it's very nice work. So I don't know if there are any more questions. From YouTube, it seems no. From here also probably we just asked. We already asked a lot. So thank you, Katharina, again for a beautiful presentation, for presenting all this work. And have a nice evening, everyone, and see you next month to the CNS talk.
Yeah, thank you very much too that I had the opportunity, and thank you for the many nice questions. And I just don't know if like with much should we talk in this session, or what was Stephanie thought because of the Parkinson project.
Yeah.
Oh yeah, with me.
Yeah. I was just.
Wait, I'm going to stop the live